Hello, everyone. I am Dr. Pooja Anand, neurologist, and today we are having a live session on a very interesting topic, which is an approach to a 20-year-old female with the first episode of seizure. Okay. So today we have chosen this topic because this is a very common clinical scenario that you all will be encountering in your outpatient clinics, in your inpatient clinics. You might even get such cases in your emergencies as well, or you might get to see them as consults in other departments. So it's very important for you to be aware on how to approach such cases, like young patients coming to you with first episode of seizure. So it's important for your clinics, and it is also important for your final exit exams in the MD. You can also get a question on the same as well. So today's session, I'll be trying to cover primarily the clinical approach, but I'll also help you all to formulate an answer for the same if you get a question on how to approach a 20-year-old female with first episode of seizure in your exit exams. So do watch the session till the end. So without further ado, now let's begin. So before we begin our approach, we should know our basics as to what is a seizure, okay? Now, seizure, as defined by the ILAE, which is the International League Against Epilepsy, now they define seizure as a transient occurrence of signs and or symptoms which occur due to an abnormal, excessive, or synchronous neuronal activity in the brain, okay? So in the definition, I want you to remember two important keywords. One, that it is a transient occurrence of sign and symptoms. So the word is transient, okay? It's not persistent. And second, that this is due to an abnormal, excessive, or synchronous neuronal activity in the brain, okay? So very simple definition of seizure, which has been given by the ILAE that you should all remember, okay? Now, this word seizure is derived from a Latin word which is called as secire. And what does this mean? It means to take possession of. Okay. So, simple basic definition of seizure. What is seizure? A transient occurrence of signs or symptoms due to an abnormal, excessive, or synchronous activity in the brain. Okay. With that key foundation, we move forward. Now, the first and foremost thing, or I would say the most important thing in the clinical approach to patient with first or rather any episode of seizure is defining the seizure semiology. Okay, so what is this seizure semiology that is so important? Now, this seizure semiology can be objective signs or it can be the subjective symptoms. Okay, simply put, what is the description of the seizure that the patient might give you, the eyewitnesses can give you, or if you witness the seizure, you find out. Okay. So the objective signs that you might see if the patient is having a seizure in front of you, or the subjective symptoms which the patient can report what they feel during the seizure or the eyewitnesses, or you can do a detailed assessment by the video recordings. Okay. So in the clinical approach, the first and the foremost important thing is to find out the seizure semiology. Okay. So how do we find out the seizure semiology? Now, as beginners, the most common mistake that we all do in the seizure semiology is that we focus completely on what was the ictal event, like what happens during the seizure. Okay. Now, although that is important, I'm not saying that's not important, but what is also important is things that happen before the seizure and things that happen after the seizure. Okay. So, what happens before the seizure is the aura. Okay. So, what is aura? How do you define aura? Now, aura, remember, are subjective symptoms. Okay. So, you cannot observe an aura. Okay, so that is something subjective that the patient is going to perceive at the onset of the seizure. Okay, so once again, what is aura? Aura is a subjective symptom that the patient is going to perceive at the onset of the seizure. Okay, so that is what is called as aura. Now, why is an aura important? Because auras will help you to lateralize, will help you to localize your seizures. Okay, now the very common aura that I want you all to remember is the epigastric aura. Now, where do you find the epigastric aura? In the mesial temporal lobe epilepsy. Now, what is the epigastric aura? It is a sensation of the stomach rising up to the mouth. Okay, so any form of an abnormal epigastric sensations, these can be help you to localize it to a mesial temporal lobe epilepsy. So that is just one example. So you can have variety of auras. Okay, the point I want you to emphasize is that unless and until you ask, you might not get the clinical description of aura, because the patients might also not know that, okay, this was happening, this was also part of my seizure. So it is your duty as clinicians to ask that before the seizure, do you get any warning or any hint that now you're going to have a seizure? And it is quite possible that in the first episode or in the second episode, the patient may not recognize this, that, okay, this is a part of my seizure. Okay, this was a part of my warning. But subsequently, when they keep having it over and over again, then they start recognizing, okay, yes, this is my warning symptom. This is my aura. Okay, so please make sure that you do ask your patients that, do you experience any aura, any abnormal sensation that happens to you before the actual event happens, and does that sensation helps you to predict that now my seizure is going to happen? Okay, so very important, ask for aura. Okay, now does that mean that an aura has happened, so whatever happens after the aura is always going to be a seizure? No, that is not the case. Okay, because you can have the aura in patients with epilepsy, but you can also have an aura in patients with migraine and patients with syncope. So you need to differentiate it from them as well. Okay. So once we have described the aura of the patient, we move to the next step, that is describing the ictal event. Okay. Now you need to ask about the patient, whatever they can tell you, whatever they remember happens during the event. Okay, or you can ask any of the eyewitness who has seen the seizure the first hand to describe you what actually happens during the event. Okay, now depending upon what happens in the ictal event, we have the ILAE 2017 classification, which is also very, very important for all of you to remember. Now see, in this classification, they have classified seizures into three basic types. Okay, now remember that these three basic descriptions, you see the word everywhere, it says what? Onset. Okay, so seizures as per the ILAE classification are classified into three categories, and what is the basis of classification is the word onset. Okay, because you might see majority of the times when you're taking the history, you might just get, okay, that there's a tonic posturing and then there are clonic movements. It is the duty of the clinician to be able to determine what happens at the onset. So it's the onset that's going to help you differentiate seizures into what is focal, what is generalized. And there are majority of the times where you will not be able to do that. And it is absolutely okay. You don't have to worry in those situations, because if you're not able to classify your seizures either into focal or generalized, then you have what we call as an unknown onset of seizures. Okay. So remember, the classification of seizures is based upon the onset. Okay, so if there is a focality, if there is a focal feature at the onset, it is focal. At the onset only, if it is both limbs, tonic and clonic movements, you will have generalized, which is the motor. And if you don't know what it is, then it becomes the unknown. Okay. Now, in the focal onset, you further classify whether your patient had intact awareness or an impaired awareness, whether your patient had motor features or non-motor features, and whether this focal seizure progressed to bilateral tonic clonic. Okay. Similarly, in the generalized, you can have, now remember, generalized seizures do not always mean that it has to be a GTCS. That means a generalized tonic-clonic seizure. Yes, that is a part of a generalized seizure, but that is not the only type of generalized seizures. You can have non-motor, such as the absence, which is the classical hallmark of generalized onset, but that does not has tonic-clonic movements. Okay, so please get that point correct. It's a common misconception that I see amongst the residents that generalized onset is equivalent to GTCS. No, that's not correct. GTCS is a type of a generalized onset seizures, but all generalized onset seizures are not going to be GTCS. Okay, so please keep that in mind very, very carefully. And if you are not able to classify into either of the two, then there is a third category, which is unknown onset. Okay. Now, going further into this classification, as this is important. So, focal onset, I told you first is whether the patient had an intact awareness or not. Then, whether the patient had motor features. Now, what are going to be these motor features? You can have automatisms. Now, what are automatisms? These are the subtle movements that you can have. So, you can have facial automatisms like the lip smacking, which can be there. There can be subtle finger movements, can be there. So those are all the automatisms which can be there. Then you can have atonic, which is a sudden drop in the tone of the body. You can have clonic movements. You can have epileptic spasms, hyperkinetic myoclonus, which is like a jerk, or a tonic, which can be there. You can also have non-motor. Okay, it's very important for you clinicians, as clinicians, to recognize that there can be non-motor phenomena as well, which can be part of seizure. It is not necessary every seizure to have a motor component. Some of the seizures can have non-motor component as well. Okay, so you can have patients having just simple behavioral arrest, having some form of sensory phenomena that can also be a part of their seizures. Okay, similarly, in the generalized onset also, you can have the motor phenomena, which can be tonic-clonic, tonic-clonic, myoclonic, in a variety of those combinations. But remember, like I said, that every generalized onset seizure does not has to be a GTCS only. You can have non-motor seizures as well in the generalized onset. Now, which are those seizures? The classical hallmark that you should remember is the absence. Okay, and the third, which remains, is the unknown onset. Okay, so remember the definition of seizures, and number two, the classification of seizures. Okay. So once you have described the semiology, that okay, this is what my patient had, this is what he or she had it in the aura, this is what happened in the ictal event, and then go on to the post-ictal, that whether the patient was confused or the patient returned back to the baseline, or was there anything significant in the post-ictal. So that's how you go and describe the semiology. So once you have described the semiology, it is not necessary that every event is going to be a seizure. Okay, so what are the differential that you should remember of the seizure? Okay, the first and the foremost common is going to be a syncope. Okay, so there can be a vasovagal syncope, it could be a cardiac syncope due to any arrhythmia or cardiac failure or an orthostatic hypotension. So the syncope is a very important differential of seizure. Okay, then you can also have psychogenic seizures, which we'll discuss in detail. Then you can have some metabolic disturbances as well. You can have migraines, you can have TIAs, you can have variety of paroxysmal movement disorders. So remember this list, which I've taken the table from Harrison, the differential diagnosis of seizures. The important ones that I want you to remember are syncope, the TIA, and the migraine. Okay, so those are very important. Now, moving down into more detail about the pseudo non-epileptic seizures. Okay. Now, why is it important for you to recognize these? Because these episodes are going to mimic a lot like seizures. Okay. And these episodes are not going to respond to anti-epileptic drugs. So many times in your clinics, you would have seen that, especially the young patients are going to come to you with a list of about 7 to 8 anti-epileptics going on and seizure frequency of about multiple episodes in a day. And when you take the history, you realize that these events are actually not seizures. So it's important for you to recognize, because number one, so that you avoid unnecessarily anti-epileptic doses in them, and second, that you can correctly diagnose and correctly treat them. Okay. So what are the clinical clues that you will get that it is a pseudo non-epileptic seizure? So when there are going to be random movements, there's going to be a random side-to-side turning of the head, the eyes are closed during the ictal event, there are going to be large amplitude shaking movements of the limbs, twitching of all the four amplitudes without any loss of consciousness, a pelvic thrusting. So when you see them, then you will start recognizing these episodes. So these are all pseudo seizures. Okay. So in general, that they last longer. and they have a very funny waxing and a waning course, which may be even minutes to even hours. Okay, so remember that every transient abnormal movements are not going to be seizures. You should remember differential diagnosis, syncope, TIA, migraines, and especially important is the PNES. Okay, so with that, we move forward. So once you have delineated that, okay, this is the seizure semiology, and yes, my patient has a seizure, I have ruled out all the possible differentials, then you need to go and take a little more detailed history. Now, especially when you have a young patient, you need to start the history right from their birth and development, okay? Because any perinatal insult, any perinatal injury, or any delay in the milestones can have an impact of an individual resulting in seizures at later course in life. Okay, so very important whenever you get a seizure case in your exam, remember to take a proper birth in a developmental history. Ask for any history of febrile seizures. Okay, that's important because if they had febrile seizures and those febrile seizures had atypical pattern in the childhood, they are predisposed to develop the seizures in the adult age as well. Okay, very important, ask for their immunization status, whether they were adequately vaccinated or not, whether this patient had any past history of seizures. Okay, it's very common that in the young patients, we find that there was an NCC which had, because of which the patient was having seizures, took treatment for about 3 years, left the treatment, was absolutely doing okay for 5, 6 years, and now has again come to you with seizure. So this episode is the first episode as per the eyewitnesses, but if you take a detailed history, you find that, okay, there was a past history of seizures as well. So it's very important for you to ask, because if you don't get the history. Then also any history in the family as well, right? Any history of a significant head trauma, any history of a significant CNS infection, and also ask a detailed history about involvement of the other neurological axis or any other systemic involvement. Okay, so you need to take a very thorough and a proper history. Now, when a patient with seizure, more important than your examination is going to be your history. And a very good history can actually help you to localize as well as lateralize your seizures just on the basis of history. Okay, so once again, remember that take a proper semiology, make your proper differentials, rule out the other causes. Then once you have made the diagnosis of seizure, do take a proper birth and a development history. Ask about febrile seizures, immunization status, the past history, family history of seizures, any history of head trauma, CNS infection, any other neurological axis involvement, any other systemic involvement. Okay. Then what are the points in the history? Now, it's not only important for you to ask for the inciting factors of seizures like infection and other things, but also about the precipitating factors. So if there is an individual who had seizures, is a known case of seizures, say a patient who's a known case of juvenile myoclonic epilepsy, they're going to do very well controlled on an anti-epileptic drug. And suddenly they present to you with emergency department with one episode of seizures. So you need to ask whether these individuals had any sleep deprivation or not. So the precipitating factors are also very important. Whether the individual, the most common being sleep deprivation, whether the patient had any electrolyte or a metabolic derangement, hypoglycemia, hyponatremia, hypercalcemia, or has this patient has developed an acute infection or has taken drugs that lower the seizure threshold like the fluoroquinones, or has intake of alcohol. Okay, so remember these few common precipitating factors. Or if it is the first episode of seizure, always try to find out whether it was a provoked seizure. What do you mean by provoked seizure? The word says it is provoked. It is provoked by what? By drugs, by toxins, can be a metabolic abnormality, or whether it is an acutely symptomatic seizure. Now, what is an acute symptomatic seizure? Which occurs in a setting of traumatic brain injury, a tumor, or encephalitis. Okay, so these are the important points that you should remember to ask in the history of a patient with seizures. Okay. Now, once you have delineated the history, you should always end your history by trying to determine what is the etiology. Now, those of you who have seen my previous lectures on the different approaches that I've covered in the PG residency section would remember this slide that I always say that there's no need to, memorize or make anything. Just remember this mnemonic of midnight with a V. Okay, so you'll be able to remember all the causes. Okay, so now when we are approaching a young female who's a 20-year-old female with seizures, what all can be the possible causes of seizure in this female? So you can have metabolic disturbances. Now, what all metabolic disturbances? You can have hypoglycemia, you can have hyponatremia, you can have hypercalcemias. Okay, so you can have metabolic abnormalities, you can have infections like HIV, TB, varicella, HSV, a whole list of infections which can be there. Then you can have drugs like we discussed, which can be precipitating. You can have the developmental disorders, the history that you will be able to delineate if you take a proper birth in a developmental history. Degenerative, we will rule out in a patient who's 20-year-old. Neoplastic also less likely in the list. Immune, yes, now which is the increasingly recognized entity of what we call as autoimmune encephalitis. Okay, very, very important, especially in young patients, especially in female, to keep immune-mediated causes as high on your cards, especially when you're dealing with the first episode of seizure. Okay, then it can be trauma, like we discussed. It can be a traumatic brain injury. It can be a toxin, like we discussed, the most common being the alcohol, or it can be a vascular injury, can be a vascular malformation, can be a young stroke, can be a lot of factors. Okay, so that is what I say, that instead of memorizing these list, okay, of what all can be the causes, just remember the mnemonic midnight V. Remember that these are the causes where everything fits, and then just remember one category and just keep putting the causes. Okay, so for a young 20-year-old female who has come to you with the first episode of seizure, what all will you think of? You will think of metabolic, infections, drugs, immune, trauma, toxin, vascular. Okay, so those are the causes that you will keep in mind while you are evaluating this patient. So once we are done with the history, we have made up a little mind about, okay, yes, my patient has seizure, doesn't have a pseudo seizure. You've taken the relevant important history, you have seen for that. You move on to your examination. Now, what are the points that you should keep in mind when you are examining a patient with seizure? Okay, so the first and foremost is that whenever you do that, make sure that your patient has a secured airway. Your ABCs are taken care of, that is the airway, breathing, and circulation. Okay, there's no active seizure ongoing. Then in the general examination, to do a quick thorough head-to-toe examination, important points to look for are any injury marks. Okay, so because of the seizure, the patient might have injured themselves, they might be having some injury marks that can be there. Important for you to look for is a tongue bite. Okay, now this tongue bite at many times gives you a clue about a true seizure, but it's not just any random tongue bite. Okay, now this tongue bite which happens on the lateral aspect of the tongue is the one which is a clue of a true seizure. Okay, then you also need to look for any neurocutaneous markers, which could give you a clue of the underlying etiology for seizures, right? And like we discussed, any signs of an active infection or a systemic disease. Now, see, systemic disease can be a part of the spectrum where seizure is just a part, or can be a contributory factor to it as well. Okay, so like for example, you can have some form of organomegalies, which could be a part of storage disorders in which seizure is a part of a spectrum. Or you can have a patient with a chronic liver disease or a chronic liver disease where the metabolic derangements are leading to seizures. So it's very important for you to screen for any systemic disease, right? So once you've done that, you move on to a detailed neurological examination. You need to do a thorough head-to-toe neurological examination, like we have discussed in our examination slides in the PG residency sections. So the important ones that you need to keep in mind when you're evaluating a patient with seizure is look at the cognitive status. Okay, so whether the cognitive status was impaired even before the seizure, or with the seizures, the cognitive status has gone down. So either of the two spectrums helps you to rule out and rule in a lot of diagnosis. Okay, and along with seizures is your patient having any other problems, like especially the myoclonus, which could be a part of seizure as well, right? So examination, just make sure to remember these points. Then, so once we're done with the history and the examination, we move forward to how do you now investigate your patients. Okay. So, in the investigations, you have the blood investigations, you have the EEG, which is electroencephalogram. Then you have a neuroimaging and you have the CSF analysis. Okay. Now, blood investigations, what all blood investigations? So, this may be asked to you in the Viva as well, like a OSCE or something, where the examiner might just ask you that you have a young patient with seizure, what all blood investigations would you, and justify that why would you do these investigations. Okay, so how will you answer such a question? So you will say that I would like to get a complete blood count done. Now, why do you want that? Because you need to rule out infection, because any active infection can be a triggering factor or can be an inciting factor for the seizure. Okay, so number one, I need to get a complete blood count done. Then I need to see the metabolic parameters, including the liver function and the kidney function, because any metabolic derangement like hyperammonemia, uremia, or can be, like we discussed, hyponatremia, hypercalcemia can predispose to seizures. Okay. Then I need to get the viral markers done because the HIV itself can result in CNS manifestations where seizures can also be a part. And our patient, being a 20-year-old young female, we need to work her up for the autoimmune causes as well. So these are the few blood investigations that you need to do. And whenever you do an investigation, you should have a reason with you as to why you want to get these investigations done. Okay. Then we come on to EEG, MRI. We'll discuss in detail about it. Now, CNS analysis, it's not like a hard and a fast rule that you need it. But yes, if you are suspecting an infective versus an immune-mediated causes, those cases, those scenarios, you should get a CSF analysis done. Okay. A little detail into EEG, although I have done a separate session discussing about the basics of EEG, what all points you should know as medicine residents. So if you haven't watched that session, please do. So EEG, simply put, is what is EEG? It's the electrical activity of the brain that we record by putting the scalp electrodes. So the way you record the electrical activity of the heart by using an ECG, and analog to that, what you do for the brain becomes the EEG. Okay. Now, any patient who has had a first episode of seizures or any patient who is suspected to even have seizures should have an EEG done. Okay, so that is a very, very important investigation. Now, the diagnostic yield is the highest if you are able to do an EEG within the first 24 hours of the seizure. Okay, so it's not like if a patient comes to you, say after 3 days, you will not get the seizure done. No, that's not the case. You will still get a AEG done, but however, the yield or the maximum pickup, if somebody asks you when is the maximum, it's going to be within the first 24 hours. Okay, and what all does in EEG will help you in a patient who's a known case of seizure or see a suspected case of seizure. So the first and foremost that EEG is going to help you is going to help you in ruling out PNES, which is the pseudo non-epileptic seizures. Now, how will it help you? Because when you have a PNES going on, you will not have the electrical activity. Whereas if you have a true event going on, you will be able to pick up some activity which will be there. Okay. So how it helps you? Number one, rules out PNES. Then in a patient with seizure, number one, it will help you to diagnose. Number two, it will help you to classify whether it is focal, whether it is generalized. Number three, it will help you to give a fair idea about the prognosis. Okay, so remember that EEG we do is not only for the diagnosis, it also helps you in the classification and prognosis of the seizures. Okay, so remember that. Now, you also need to remember that just because your patient has a normal EEG report does not mean your patient does not has a seizure. Okay. Now, why do I say that? That even in a patient who have been a diagnosed case of epilepsy, if you do an interictal EEG, what do you mean by an interictal EEG? An EEG which was done when the patient did not have any episodes, that can be normal in about 50 to 80% of the times. Okay. So even in patient who is a known case of epilepsy, routine interictal EEG may be normal in 50 to 80% of the times. Okay. So if your patient whom you are suspecting to have seizure comes to you and shows you a normal EEG report, please don't be in a impression that my patient does not have seizure. Your patient can still very well have seizures. Okay, so please remember that as residents. A normal EEG report is not equivalent to your patient not having seizures. Okay. Then moving on to the neuroimaging. Now, as per the guidelines, all patients who have new onset seizures should have a brain imaging except. So I put two question mark there. So which are the patients who are excluded? The patients who are excluded are the ones who have a confirmed diagnosis of idiopathic generalized epilepsies, like the childhood absence, the juvenile absence, the juvenile myoclonic. Those are the patients where you don't. But apart from that, all patients who have a new onset seizures should have a brain imaging done. Okay. Now, in this brain imaging, the preferred modality is an MRI brain. But however, if you are working in a resource limiting settings where you're not able to get it, please get a CT brain done. Okay. But remember that all patients with the new onset seizures should have a brain imaging done. Okay. Now, in the imaging, it is not just the CT and the MRI that we talk of when we're talking in spectrum of the epilepsy or seizures. In the patients who have a very variety of drug refractory seizures, you also have functional imaging, which can be either PET, which is positron emission tomography, or you can have SPECT, which is single photon emission computed tomography. So if you're able to remember this, it's well and good. If not, at least remember that all patients with new onset seizures should have a brain imaging done. A preferred modality would be to get an MRI brain done. However, if you are not able to get it because of the resource limited settings, please get a CT brain done. Okay. Now, this is a slide that is very important because this is one imaging that I want you all to be able to recognize whenever you see. Now, this is a photo that I have taken from your Harrison. Okay, all the more reason that you should be able to recognize this because this is important, can be shown to you as a spotter, as an OSCE, or can be kept as an MCQ as well for your entrances. So this is what is the hippocampal sclerosis, which is a cause of the mesial temporal lobe epilepsy, which is the most common focal epilepsy that we see. Okay. So what is this? So you see that there is an abnormal high signal. There is a blurring of the internal laminar architecture. And as compared to the normal size, the size there is reduction. So this is what is the triad of hippocampal sclerosis, that there is an abnormal signal intensity, blurring of the internal laminar architecture, and reduction in the size of hippocampus. Okay, so if you're not even able to remember the triad, just remember the hippocampal sclerosis. You look for the hippocampal sclerosis in the coronal sections. Okay, you look for them in the coronal sections as we have seen here, and they are the cause of mesial temporal lobe epilepsy. Okay, so just remember this one imaging finding, very important for all of you. So once we are done with the history, we are done with the examination, now we have seen how we need to investigate the patient, we all come down to the bottom line that now what do we have to do for the treatment, okay? So our patient is a young female who has come to you with the first episode of seizure. Now, had there been a recurrent seizures or a patient who's having repetitive seizures, we were clear that we have to start her on anti-epileptic. But what do we do when we have the first episode of seizure? Do we start or do we not start? Okay. So when to initiate treatment? Now, by treatment, I mean the anti-epileptic drugs. Okay. For patients who are coming to you with the first episode of seizures. Okay. So if your patient has had a prior brain insult, like a stroke or a trauma or a CNS infection that has been there, you need to start these patients on anti-epileptic. Or if you do a brain imaging now and you find there is a significant abnormality, so either a prior brain insult or a current imaging showing you abnormality, EEG showing you epileptic form abnormalities, or if your patient has had nocturnal seizure. Now, why nocturnal seizures out of all? because if a seizure happens to them in sleep, that is when they're maximally prone to develop an injury and they might not be able to get any help at that point of time. Okay. Or if your patient has a positive family history of seizures. So these are the certain scenarios where we start treatment even when the patient has had first episode of seizure. But remember, on the other hand, we have a spectrum where it was a provoked seizure, where you had a metabolic abnormality, say a hypoglycemia or something like that, where we know that this was the cause of seizure and that was only one seizure. In those situations, we generally treat the underlying etiology, and if that is treated and the patient remains seizure free, we do not add anti-epileptic drugs. Where all do we add the anti-epileptic drugs? If your patient had a prior brain insult, your EEG is showing abnormalities, your brain imaging is showing abnormalities, patient has had a nocturnal seizure or has a positive family history. Okay, so these are the few scenarios where you add antiepileptic even in the first episode of seizures. Okay, but do remember that you need to find out what is the underlying etiology and you need to treat the underlying etiology. Okay. And even despite that, you always have to educate your patient on avoiding the precipitating factor. The most common precipitating factor for seizure is going to be the sleep deprivation. So please counsel them that all your patients with seizures should have a proper 8 hours sleep. And it's not any 8 hours during the day, it has to be properly from 10 p.m. to 6 a.m. preferably. They should have a good 8 hours of sleep. Okay. Now, when we have decided that, okay, we have to treat our patient, so what are the treatment options that we have? So this I have taken from your Harrison. Now, although you will find a certain form of discrepancy from one source to the other, that is absolutely right. But however, the one source that you should stick to as PG residency, PG residence is your Harrison. Okay, so whatever Harrison says, Harrison is your Bible. You have to follow it. So for your generalized tonic-clonic seizures, they have given the options as lamotrigine and valproic acid. Although I'll come to it that why valproate is not a good choice in a young female. For focal, they have given you the options of lamotrigine, carbamazepine, and the congeners of carbamazepine, which is oxcarbazepine, eslicarbazepine, phenytoin, levetiracetam. Okay. Then the absence and the other ones which can be there. So right now I'm focusing mainly on focal and generalized tonic-clonic. For typical absence, you have the valproic and the ethosuximide. For atypical or the ones with myoclonus, again, you have valproate, lamotrigine, or topiramate, which can be given. Okay, so these are the ones. This particular slide is something that you should all remember by heart. Okay. Now, so we have come to the point where we know that, okay, our patient needs treatment and what all treatment options we have. Okay. But the patient that we are discussing today is a young 20-year-old female. Okay. Now, what are the treatment considerations that we have for, especially for females, when we are choosing their anti-epileptic drugs? Now, remember that we focus primarily on the pregnancy and the reproductive part, but it is not just that when it comes to females in the choice of anti-epileptic drugs. Even a part before, which is like the menstrual point where you have catamenial epilepsy, and even after that, in the old age as well, a lot of considerations need to be made when you're choosing anti-epileptic drugs for a female patient. Okay, so I'll be just giving you a few key points that you should all keep in mind when you're prescribing anti-epileptic drugs, especially to a female. Okay, now in a woman of a childbearing potential, you should avoid valproate as much as possible. Okay, now having said that, it is not that suppose if a patient comes to you, she's a young female, okay, of say a juvenile myoclonic epilepsy who has been doing very well on valproate. It's not like that you go on reducing and stopping the valproate. No. If your patient is controlled on valproate, is doing very well on valproate, is not having any side effects with valproate, it's not a hard and a fast rule that you reduce it and you stop it. But if you are initiating the treatment, always make sure that if you are able to have other options other than valproate, you should choose that. Having said that, yes, valproate is a very good drug. It's a very good anti-epileptic. There are situations that even in a childbearing potential, we do have to add it. But whenever you do, make sure that you educate your patients about the potential harms that it can be causing. Okay. So try your best possible that in a childbearing age, try to avoid valproate as much as possible. Now, what is the one effect that is we are always dreaded is the PCOS, which is the polycystic ovarian disease. Okay. Now, moving forward, we have something which we call as catamenial epilepsy. I'll not be going into much detail, but just to tell you that it occurs in about 1/3 of women with epilepsy. And what is catamenial epilepsy? Now, it is the doubling of the seizure frequency almost exclusively during the specific times of the menstrual cycle. Okay. Now, see, remember that every female patient may have some form of exacerbation of her seizures at the time of the menstrual cycle, but that is not catamenial epilepsy. It has a very strict definition that it has to be the double. So if a baseline frequency is, say, about 2 to 4, it goes to about 4 to 8 at some specific points in the menstrual cycle. Only then it is labeled as catamenial epilepsy. Okay. Then a few key points that I want you to remember, because these have a lot of social impact when you are treating patients with epilepsy. Okay, so there are going to be a lot of times that the family is going to come and they will ask you that, okay, doctor, the patient is on my patient is a young female. We're doing very well on the anti-epileptic drugs, but is now getting married. And because of that, she might not, because of the epilepsy, people might not be wanting to get her married because it's going to impact her fertility. Please remember that if your patient does not has a pre-existing infertility issues, women with epilepsy have the same chance of conception as compared to women with epilepsy, right? So if you have two patients and both of them do not have infertility, one has seizures, the other doesn't have seizures, the chances of conception are exactly the same. Epilepsy drugs do not hamper the chances of conception in patients with epilepsy. This is something that you really need to educate your patients about and also keep in your mind. And very important is that periconceptually, you should always add folic acid to your females who are on anti-epileptic drugs and are also in the reproductive age group. Okay, so it's a dose recommendations is about 0.4 to 5 milligrams daily for at least 3 months prior to conception. So remember, whenever you are adding anti-epileptic drugs to patients who are young females in the reproductive age group, number one, try to avoid valproate. If you're not able to, make sure that you educate them about the side effects of valproate. Number three, you add folic acid empirically in a dose of about 0.4 to 5 milligrams. Okay. Then during pregnancy, now then again, so one is the biggest hurdle as clinicians that we have is when females are getting married, they're going to leave their drugs because they feel that it's not going to, hamper their conceptions. That's one myth that you have to break, that there is no impact on the fertility because of the anti-epileptic drugs or because of the epilepsy. The second is what happens during the pregnancy when a patient with epilepsy becomes pregnant. Now, in 50% of the patient, the seizure frequency will remain unchanged. There will be an increase in 30%, and it might actually decrease in 20% of the patient. Now, these percentages have taken from Harrison. So important for all to remember that in 50%, it's going to be the same, like before and after the pregnancy, during the pregnancy. 30% of them might have an increase, and 20% may actually experience a decrease. Okay. And overall incidence of fetal abnormalities in a child who's born to mother with epilepsy is just 5 to 6%. And this, even in a healthy woman, is 2 to 3%. Okay. So these are few percentages that you should remember. Can be asked to you in your OSCEs or vivas, or can be a potential MCQs as well. That what happens to the seizure frequency? It remains unchanged in 50%, increase in 30%, and decrease in 20%. And fetal abnormalities in a patient with women with epilepsy, it's about 5 to 6%, whereas in a healthy, it's about 2 to 3%. Okay. And what are the common malformations that we see are either cardiovascular or musculoskeletal. Okay. Then what about contraception? Okay, so you need to tell that there are few anti-epileptic drugs which can reduce the efficacy of oral contraceptives. Now, what are those anti-epileptics? Carbamazepine, phenytoin, phenobarbital, and topiramate. So carbamazepine, phenytoin, phenobarbital, topiramate. So if your patient is on these anti-epileptic drugs and is on simultaneously OCPs, you should advise them that they need to consider alternative forms of contraception. Okay. So, like I said, that whenever you are choosing anti-epileptic drugs in females, you need to keep a lot of things in mind, especially when they are young females in the reproductive age group. You need to take care of the contraception. You need to take care of them when they're pregnant or when they are planning pregnancy as well. Okay. Then what all are the complications? So once we are through to almost the major part where we have done the history, the examination, the differentials, the investigation, the treatment, given considerations to the female. So what are the complications that can happen even with the first episode of seizures? Now you need to tell and educate your patients that there can be something which is called as SUDEP, which is a sudden unexpected death in epilepsy. And that generally happens in young patients, especially the ones who have convulsive seizures. Okay. So please educate that that is the reason they need to be very extremely compliant with their medications and not miss them. Now, this event generally happens during the night. Now, why it happens is generally not known, but it is postulated that it is because of the brainstem mediated effect on the pulmonary, cardiac, or the arousal functions. Okay. So remember, SUDEP is one of the most dreaded complications that we can have, which is basically a sudden unexpected death in epilepsy. Okay. The other dreaded complication that we have is the status epilepticus, which has been discussed in detail in another session. So you can watch that. But remember that these are the two potentially dreaded complications, right? And apart from that, any seizure can be potentially life-threatening, can result in potential injuries to the patient, can result in aspiration and other complications as well. Okay. So that is why, as clinicians, it is very important for you that even when the patient comes to you with just one episode or the first episode of seizures, please don't send them off, okay, this is fine, this is only one, right? Because that one can also be life threatening to them. Okay, so do take a detailed history, have a proper examination, investigate these patients, and decide whether my patients need the treatment. If yes, choose the appropriate drug. And the drug is generally not because just as a first line has to be given. Take into consideration the age of the patient and the various other factors that we had discussed, and make sure that you educate your patients about the potential complications that can happen because of seizures. Okay. So in the summary, like I said, so putting it all together that we have learned today is that whenever you have a patient with seizures, identify their semiology, which is the first and the foremost important step. And remember, in the semiology, it is not only the ictal event that is important. What happens before, that is the aura, and what happens after, which is the post-ictal state, are also very, very important. Number two, remember that whenever you are evaluating, rule out the pseudo non-epileptic seizures. Take a detailed history and examination and classify your seizures. And remember that the classification is based on the onset, whether it was a focal onset, whether it was a generalized onset. And if you don't know, then it is an unknown onset, which will be there. Okay. Remember the important considerations that we had discussed before you initiate anti-epileptic in your female patients. Okay. So with that, we conclude the session. So if you have any questions, I can take it, or if not, then you can mail me or send a message directly on my Instagram page, and I'll be very happy to answer them for you.
Thank you, ma'am.